Thank you everyone for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch is titled, How MU and HIPAA Audits Change Provider Management of IT Security. We're joined today by Mike Semel of Semel Consulting. Mike is one of the top HIPAA experts in the country, and we work closely with him here at Format Approved. You could not find a better resource to address today's topic, and it will be a very informative session, so thank you for joining us. Remember that you can ask questions of Mike at any time during the session by entering them into the chat area. In the second half of our session, we'll address as many questions as time allows. If we do run out of time, answers to those questions will be posted to our website and sent via email link later in the week. So if we don't get to your question, Mike will give you a written answer. And sometimes if people ask complicated or technical questions, we may be better to address it in writing. Also, please note that all registered attendees of today's session, whether they attend or not, will receive an email with links to both the slides and the recorded version of this event. Well, to begin, Mike, thank you so much for joining us. It's always a real pleasure to have you with us.
Glad to be here, Brian.
All right, well, let's get right into it if you don't mind. I think it's a good idea to just give us a little bit of history of how we've come to where we are with HIPAA.
Okay, well, I'm not going to define HIPAA. I think most people understand the rules, and if they don't, that's really not the topic for today. We're going to talk about audits. And just wanted to remind people that HIPAA goes back to 1996, the Health Insurance Portability and Accountability Act. And originally it was designed so that when people changed jobs, they would be able to be insured by the health insurance provider at the new employer. It also gave us COBRA. So HIPAA goes back to 1996 dealing with insurance. But the things that most people are concerned about and where HIPAA has really kind of morphed into the privacy and security areas. But it's a reminder that back in 2003, the privacy rule became effective, and that protected all patient data. And then 2 years later, in April of 2005, the security rule kicked in, and that protected electronic data. The reason these things are important to today's conversation is that a lot of people have been asking about meaningful use. When we started this broadcast, we talked about the MU audit. That's for the Meaningful Use Program, which is the Electronic Health Records Incentive Program, the financial assistance that practices and hospitals get for implementing medical records. So that came about in 2009 as part of the HITECH Act. And the HITECH Act is actually a funding law. It was part of the ARA, American Reinvestment and Recovery Act, and it was a funding package, and it gave us meaningful use. It also changed some of the HIPAA rules. So in 2011, the Meaningful Use Program kicked in. Just over 1 year ago, January of 2013, the HIPAA Omnibus final rule was announced, and that changed the data breach reporting. It changed a lot of things within HIPAA. So just as a review, the security rule, which governs electronic data, goes back to 2005. And the Omnibus rule is now just over a year old. And when we're going to talk about audits, they're going to relate back to HIPAA as well as meaningful use.
All right, well, what does HIPAA say about audits then, Mike?
Well, the HIPAA rules on audits actually changed a little bit. And this is the actual wording out of the laws, or out of the rules that came about from the law. So that in 2005, when the security rule came out, compliance was being handled by CMS, the Centers for Medicare and Medicaid Services. And the law at that time said that the secretary, when we talk about the secretary, it's the Secretary of the U.S. Department of Health and Human Services. And it said the secretary may conduct compliance reviews to determine security rule compliance. Then in the HITECH Act, and part of this had to do with the fact that it was a funding law, and that there was money now going to be on the line through the Meaningful Use Program, and the new law said that the secretary shall provide for periodic audits. So it basically took it from being an option to being a requirement. And at the same time, when these laws were being changed, the compliance moved from CMS over to OCR, the Office for Civil Rights. They're both departments within the U.S. Department of Health and Human Services. However, they are different departments. And some of this came about because of Inspector General reports. So every federal department has an Inspector General. And they're kind of like the internal affairs department of a police department, where they investigate. So on television, we see internal affairs investigating police for doing things that are not correct. The Office of the Inspector General looks at the departments within their agency to see if they're doing things right. And they were critical back in around 2008 about CMS enforcing HIPAA at the level that they thought it should be enforced at. And that was one of the reasons why the compliance enforcement was changed from CMS over to OCR. And it may have been one of the determining factors that changed audits from being optional, that they may conduct them, to being required, that they shall provide.
So how many HIPAA and meaningful use audits have there been, and how many breach investigations have there been?
Well, it's funny because we talk about HIPAA audits, and it's almost like they're not even real. So the odds of winning the lottery are probably greater than getting audited for HIPAA. And the reason I say that is that the original HIPAA audits were of hospitals. There were only 7 hospitals, and this is back in the late 2000s, 2008, 2009. There was an audit, a pilot audit of 7 hospitals, and what they were really trying to determine in the audits were some areas that needed attention in terms of educating the healthcare providers in terms of what they needed to do to comply. In 2012, audits were funded. There were only 115. Now, when we say that the odds are small, look at that number of 700,000 covered entities. And with the omnibus rule that kicked in last year, we now have all the business associates. So if you figure that every covered entity is going to have at least 2 business associates, we're looking at over 2 million potential audited entities. So the covered entities plus the business associates now would exceed 2 million. And like I said, in 2012, they did 115. There were none last year. It had to do with funding. Leon Rodriguez, who is the director of the Office for Civil Rights, said that in 2014 there will be more audits, but even if they doubled or tripled or quadrupled the audits, let's say they did 1,000 audits, you're still looking at 700,000 covered entities, maybe another 1.4 million business associates. So audits are not, HIPAA audits are very few and far between. That changes when we go to breach investigations. There have been over 13,000 data breach investigations. In some cases, people self-reported when they lost a device or when they sent bills to the wrong people or stuffed envelopes incorrectly. And in other cases, they were turned in. So there were over 13,000 data breach investigations, and that's resulted in over $10 million in fines. Now, when we look at the fines, people say, well, it doesn't look like there are a lot of fines. If you look at 13,000 investigations and 10 million in fines, keep in mind that when you're investigated, you can have a lot of costs, and your costs to remediate the problems and notify your patients can exceed what a fine would be. So don't look at this as just something that is going to be a low-risk, low-cost endeavor. If you're investigated for a data breach, you're going to have to notify your patients. We've seen numbers around $100 per patient to be notified, and when you start looking at the number of patient records that are stolen, 2,000 here, 4,000 there, 10,000. There was a recent breach of 800,000 records, and then the Advocate Healthcare breach in Chicago was 4 million patient records that included Social Security numbers, so they're actually paying for credit monitoring for their patients. So when we look at these 10 million in fines, I think it's just really the tip of the iceberg in terms of what the true costs were to the organizations that were investigated. Now, when we get to meaningful use, we're in a whole different area. So HIPAA is compliance. The law says you have to do this. An audit would compare what you're doing back to the law, and potentially there'd be violations, but it also could be just a corrective action plan that you need to get policies and procedures, or you need to train your employees, or do some things to better secure your technology. But that's the whole concept of the HIPAA audits. Data breach investigations are tied to an event. Some sort of data, some information was released. So when you have a data breach investigation, even a lot of those come back with just a corrective action plan. When you're dealing with meaningful use, now you're into federal money, which specifically is Medicare money. So when you're talking about meaningful use in Medicare, and in the states it would be Medicaid money, now if you're not compliant, you have a financial payback, perhaps at the minimum. In other words, if you're not compliant, they could say send the money back or not send you the money. And there are other enforcements that could take place. First of all, probably the best scenario, if you were caught and in an audit or an investigation, you would have to give the money back. So if you were in the meaningful use program from the very beginning, then you're looking at, and you're a provider, you're looking at around $44,000 per doctor. When we get to hospitals, they're in the millions. In a hospital company, I believe it was Healthcare of America, recently had to give back $11 million in meaningful use money. So this is happening, and what we're finding out, and some of this information is not clear. We're hearing it from different sources, but we're seeing audits, instead of 115 audits out of 700,000 covered entities, we're seeing ratios of 1 in 20 up to 1 in 7 being audited for meaningful use. And if you fail the audit and you can't provide them with the specific information that fits the criteria to prove that you attested properly, then if you give back the money, that's 1 times the money. That's the money that they were going to pay you or that they had paid you. However, they can also use the Federal False Claims Act. And the False Claims Act, it's called the Lincoln Law. It goes all the way back to the Civil War, when companies were making uniforms and tents and things like that for the Union Army, and they were of poor quality. They got paid a lot of money, and then the materials fell apart, the coats fell apart, and the tents came apart. So there was a lot of fraud going on. This law provides for triple damages. So if you were supposed to get if you got your $12,000, your $18,000 payment last year, and they believe that you defrauded the government, then there are 2 choices. One is false claims, where they can come back and get triple the amount of money. So now if you're a medical practice with, say, 20 doctors and you're up around $1 million in meaningful use money, they could come back to you for $3 million. And the hardest penalty would be criminal. And that would be that if they believe that you were criminally defrauding the government of its meaningful use money, that would be prosecuted, and that would be a criminal offense. So if you fail a meaningful use audit, then you're going to likely have to give back your money or pay 3 times the amount of money if they invoke the False Claims Act, or perhaps be criminally prosecuted. It's more likely you're going to get audited for meaningful use than HIPAA by itself, and the penalties are much greater because it gets right into your pocketbook.
Yeah, those odds are not very good to try to skate by without doing what you're supposed to do. Just to amplify this point, Mike, so the deal here is that meaningful use, Core Rule 15 says you must conduct this risk analysis. So it's sort of like they tied meaningful use to HIPAA. Is that a fair way of describing it?
Yes, it is.
Oh, well, I think we just jumped ahead a little bit, but so go ahead and just explain a little bit more, if you need to, how these two are connected.
Okay. So first of all, Brian, you mentioned Core Measure 15, and the core measures change depending on the stage and the date, basically. So it's either Core Measure 15 or Core Measure 14, and it also may be a different number if you're an eligible professional or a hospital.
Good point.
But it's the same requirement. So most of the core measures in meaningful use are tied to the actual use of the electronic health record system. And they're statistical. And for example, you have to ask people who are over 13 years of age if they smoke. And that's the type of thing that's calculated within the system. I'm not going to get into all the stage 1 and stage 2 core measures, other than to say that this core measure for a risk analysis, and it's specifically, the objective is to protect the electronic health information. And there's a lot of information surrounding this, but basically you have to conduct the risk analysis. And what's confusing is the government terminology. The government, for whatever reason, and this is the Office of the National Coordinator that runs the Electronic Health Record Incentive Program, didn't use plain English when they created this rule. So it talks about conduct or review a security risk analysis in accordance with, and then it says 45 CFR 164.308A1. That's government lingo for the Code of Federal Regulations section for the HIPAA security rule. So people are confused when we're doing a risk analysis, or when we're talking to them about the risk analysis for meaningful use, and we start talking about HIPAA, they don't get it. And I can't blame them, because when you read this terminology, this 164.308A1, it's a foreign language, it's government speak, but it's specifically where HIPAA and meaningful use overlap. And the risk analysis not only is tied to the specific use of the electronic health record system, but they published a lot of guidance. There's some myths and facts that have been published about meaningful use, core measure 15 or 14. And it says also that it's not just limited to the protection of electronic health information that's within the certified health record system, but anywhere in your network or anywhere in your environment. So this is where HIPAA and meaningful use overlap.
So you work with practices all the time on helping them meet their compliance requirements. What are the things that you often see that would cause an organization to fail one of these audits?
Well, first of all, the people that we deal with in healthcare in most cases are not IT experts, and they're not familiar with networking technology and even how their systems work. And many organizations have said to us that all of their protected health information, their EPHI, is in their electronic health record system. We've been doing this for over 10 years, and that has never been the case. When I was the CIO at a hospital, my greatest nightmare, the thing that kept me up at night, was not the information that was in our electronic health record system, but it was the information that we had exported from it or had created separately using a different system. So when we look at where the protected data is, we had an electronic health record system, and our department managers used to ask us to export data from it all the time for some sort of report they had to do, either for their department or for the management of our hospital, or even the state and other regulators, where they had to send information to them. So we find information not just in the electronic health record system, but practice managers have things like letters, appeal letters to insurance companies. We find lots of reports. We find scanned images that are either faxed in or been scanned and attached to a record or kept in someone's computer, even in the copier itself, where people don't realize that there's a hard drive. We find doctors that are carrying laptops around that have patient information in. There was a data breach earlier this year where a doctor that had multiple offices had been carrying a thumb drive back and forth between the offices, and the thumb drive just disappeared. He had all of his patient records. There was thousands of patient records on the thumb drive. So most organizations think that their data is in their EHR system. Another problem we find is particularly in small practices where they're using consumer-grade technology. We'll talk more about the difference between consumer-grade technology and business-class technology. But one of the big problems is that you can't just go buy a computer or a device, like a networking device, from a retail store and have the same level of protection that you would get with business class technology, and that's what you need to protect patient data. Everywhere we go, we find that users are logging in with generic passwords, nurse or doctor or something like that, not their name, and in some cases, the nurses are logging in as the doctor to get into the network or the electronic health record system, and there's no way to trace back who was actually in the record, which is a fundamental requirement of HIPAA. Another thing we see is that because it's inconvenient to have to log in when you're talking to a patient or when you walk into an examining room, a lot of systems are just not set to lock. And when you walk in, all you have to do is jiggle the mouse and you're in the patient care system. And that happened to me recently when we were doing an assessment where I walked up to a computer, just jiggled the mouse, and got right into medical records without having to enter any credentials at all.
So what are some other causes that you've run into for people to fail an audit?
Well, when I tell people to think outside of the box, I'm not telling them to be creative. I'm telling them to think beyond the walls of their organization and think of the vendors that they work with. So a lot of organizations don't have good business associate management, and they don't completely understand necessarily who business associates are, and don't think about patient information that may end up in a business associate system. One of the common areas that we find is when practices have answering services, we're finding that the answering service takes a message from a caller after hours or on a weekend, and sometimes they're sending the message by text, which is totally inappropriate. You can't use text messaging for HIPAA unless it's a secure service, but they're keeping a record of who called and what the message was, and then they relayed that message to the doctor. So that's just one example out of many where the vendor has patient information, and for most practices, that's kind of out of sight and out of mind. So they don't think of business associates when they're thinking of protecting their data. In smaller practices, we find doctors who tell me that they're the IT guy, and had one recently that said his son was his IT guy. And if you're a certified IT security professional, that's okay, but just the fact that you can set something up and that these IT companies or the product companies have made it easy to turn something on and get a network connection or be able to start working pretty quickly once you turn the system on after clicking next, 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 and agreeing to some terms and conditions, it doesn't mean, number one, that it's set up securely, and then the systems have to be monitored for security after they've been installed. So people trying to do it themselves is okay at home, but it's not okay when you have to protect patient data. And then the last thing is we talk to a lot of practices that tell us, you know, yes, we do this, yes, we do that. And when we ask, can you provide evidence, written documentation, that you actually have done that you have policies in place, or can you prove that your people have had their trainings for HIPAA on an annual basis? The answer is, well, we do it, but we don't have any evidence or documentation. So this is one where even if you're doing the right thing, if you don't have good documentation, you're going to fail an audit.
Well, that's all great advice in terms of what can trip people up. What should a healthcare organization do to survive an audit?
Well, the first thing is that you have to think like an auditor or an investigator. When we ask people, you know, is your documentation adequate? And we're thinking that you need, you know, over 100 pages of HIPAA policies, and they hand us one page, and they say, yes, here's our HIPAA policies. We don't think that an auditor would accept that. HIPAA, just the omnibus rule, just the changes to HIPAA that occurred a year ago, took 562 pages to document. Those were the changes to the original 2003 security rule and the 2005 security rule. And 562 pages. There's no way you're going to satisfy an auditor who's asking if you're complying with that rule by handing them 1 or 2 pages of documentation. So you have to think like an auditor or investigator. First thing is you have to be critical and objective. People say to me, well, we're going to do our own risk assessment. Well, okay, but if you did your own IRS tax audit, would you ever pay any more taxes? You know, most people would give themselves the benefit of the doubt. They would ignore things. It's just human nature that you're going to not be as critical on yourself. So when you're looking at your organization from the terms of auditing, be critical and objective. And also conduct internal audits. Prove it is not a 4-letter word. And in the financial ends of medical organizations, the chief financial officers and the controllers and the people that handle the finances, they're in an industry, the whole financial industry is based on auditing. And you don't insult a chief financial officer when the accountant calls up and said it's time for an audit, or when the bank says, we need your audited financial statements because you want a loan to put on this new addition to your building. So the auditing is something that people in the financial business deal with all the time. In healthcare, we see health audits. So you have organizations like the Joint Commission and others, and including OCR for HIPAA and the Office for the National Coordinator for Meaningful Use. It's pretty obvious what they're looking for. So you can conduct internal audits periodically. The other thing about auditing is that it usually takes place long after an event. So it's faster with meaningful use, but with HIPAA, they may audit you and say, we want to see all of your records from 2013 or even 2012. Why can they do that? Because HIPAA requires that you keep all your documentation for 6 years. Where did the 6 years come from? We go back to the beginning of this conversation. We said that HIPAA was originally written and enforced by CMS, the Centers for Medicare and Medicaid Services, and the Medicare regulations for document retention are, say, 6 years. So they'll go back and say, we want to see your records. It's 2014. They could say, we want to see your records for 2008 or 2009 that show that everyone was trained. And if you can't provide that information, you're going to fail the audit. So the first thing is that you need to do the right things. The second thing is you need to create good documentation and retain it for 6 years.
And, you know, I think that's...
may have some other rules also.
I was just going to add, you know, for meaningful use too, you know, we've heard that the main reason why people tend to fail those meaningful use audits is that they said that they did the risk analysis but didn't actually do it or didn't do it properly. But the other thing to keep in mind is that if you've gotten 3 years of meaningful use and you haven't had a risk analysis, it's not 1 year of payments that you stand to lose. It's all of those payments. They can go back to any of those years and claw that money back.
Well, right, Brian, but also keep in mind that meaningful use is a carrot and a stick approach to implementing electronic health records. So not only might you have to give back the money that you've received, you may be dinged in the future for Medicare payments. So right now the money is flowing towards the providers and the hospitals for implementing electronic health record systems. Starting in 2015, if they haven't implemented meaningful use in electronic health records, then they're going to start receiving less money in terms of reimbursements.
That's a great point, and those penalties grow year on year once they start to kick in, so the stakes go up and up. So here's some what sound like spy terms, but tell us what this means. What should providers know about reconnaissance and protection in the context of HIPAA and meaningful use?
Well, reconnaissance and protection, search and destroy, whatever term you want to use, is basically saying that you can't protect electronic health information until you know where it is within your organization and also externally and how it flows in and out. So when we work with practices and hospitals, sometimes we're not surprised by it, I don't think anymore, but they're often surprised when we show them where protected health information is even within their own systems, internally in their buildings. So it's sometimes on local PCs. The problem with local PCs is if they're a laptop, they may get carried out of the building. in many cases, in most cases in our experience, local PCs aren't backed up. So if there's data on a local PC and the computer is stolen, or if the hard drive fails, you may lose that data permanently. And that could have a business impact. It also could put you at risk of non-compliance, again, because you're supposed to retain information for 6 years. Servers. We have a lot of healthcare organizations that have file servers. Sometimes it surprises us that they have a server, but they still have a lot of data on local PCs. But in most cases, it's easier to secure data that's on a server rather than having it all over the place on different devices. Portable devices, it's kind of a catch-all for tablets, for smartphones, for any of these new devices that you can carry around with you. But I would also extend that to things you may not think of, like tape recorders. We have medical practices where the doctors are carrying the digital tape recorders to dictate notes, and even those have patient information. They're going to say the patient's name. They're going to talk about what the diagnosis or treatment needs to be. Phone systems. In the old days, phone systems recorded messages on tapes, but newer phone systems, both in a building and also the ones that are in the cloud, record messages digitally, and in some cases turn them into emails and even synchronize them to cell phones. Copiers. People don't think of their copiers as computers, but some of the larger copiers, typically not the small multifunction ones that are like the desktop printer, but the larger ones have hard drives in them, and the hard drives have images of all the paper that gets scanned or copied or even faxed in or out. Those are the things internally that we find within practices and hospitals. Externally, technology vendors, IT vendors. And this is surprising, but I've run IT companies for many years, and we have our technicians carrying around these USB hard drives so that if they're going to go to a client site and they need to move data, they can move it onto the hard drive, then move it to the new device. Sometimes they offer remote services like online backup and things like that. But your IT company may have patient data, and they may not even have the software to open it, but they may be walking around with patient records on a hard drive. The copier repair tech. We've already said that the copiers have internal hard drives. If the copier repair tech comes in, finds a problem with that internal hard drive, takes the old one out, puts a replacement in, he just walked out the door with patient records. And he may send them back, or he may throw them in a dumpster, and that could be a data breach right there, and nobody would consider that typically when they're identifying the types of breaches that could occur in a medical office. Your electronic health record vendor may have your records because one of their technicians may have taken data, or they have access to your data. The cloud. Now, the cloud is just a very generic term for any type of service that's delivered through the internet. So you have services where a lot of us individually may have our family pictures out in the cloud. We may have it at the drugstore that has a photo department, and we put our pictures out there so that we can go and get prints or share them with our family. There are file sharing services, and this is something that we found smaller medical practices have been using, because they can put some records or images or x-rays up in the cloud at a file sharing site and either have a specialist access it, or if they go between offices, and we find a lot of smaller providers have office hours in different locations on different days, so they can go back to the cloud up into this file and pull down the information or the image, and many of those are not compliant with HIPAA. Then there are contracted services like transcriptionists and coders. I'm not talking about ones that are employed by the practice, but maybe people at home or on a service that you get remotely. If an attorney is representing a doctor in a malpractice case, any of the patient information is protected by HIPAA, and it's the practice's responsibility to make sure that's protected. Accountants that audit healthcare facilities, collections agencies. So the first thing you have to do is find out where all this stuff is, and then you need to control the access and make sure that your vendors are compliant, but this is a hard thing for many practices to do in hospitals. If we find people in one doctor practices all the way up to hospitals with hundreds and hundreds of employees that are having a problem keeping control over their data.
All right, I'd just like to remind our guests that all registered attendees of the session will receive slides of the event. Some of you have asked about that, and you also get a recorded version of it. And we do have questions already. We're going to save those for the end of our session, but feel free to ask additional questions now, and we'll get to as many of those as we can. All right, let's continue, Mike. So you mentioned before this issue of, kind of consumer class technology versus business class technology. What does that mean, and why is it important?
Well, the differences in most cases are not in functionality, and this is kind of the scary part, that you can buy a computer that's on sale that you see in a Sunday ad and take it to a medical office and get it to work. So, you can turn it on, you can get to word processing, you can get to the internet, you can log into your electronic health record system. The problem is that consumer class operating systems don't have security features that are built into business class operating systems. And there are some very specific features in terms of, can you lock the device using a password? In some cases, can you join it securely to a network? There are a lot of different characteristics between a business class and a home operating system. But what we find is that unless you're going to go and have spent a little more effort, I guess, buying a system, chances are you're going to get one with a consumer operating system. So where do you get the business class operating systems? Any IT professional company can help you select those, and it's pretty simple to find one, and then it has to be installed properly. In most cases, you don't find them in retail stores, but if you go online with a vendor, you can look and see. And the types of things we're looking for would be something that says professional. So a lot of organizations are using Windows. Some of them haven't gone to Windows 8 and are still using Windows 7. But if you just look at your computer and you go to the Start menu and look at the Computer tab and right-click on it, it'll tell you what the operating system is. And what we're looking for is something like Windows 7 or 8 Professional. There are some other versions. There's Enterprise and others that also have these security features. Most portable devices and desktop computers don't have the security built in to properly protect data. And also, when you're trying to back up data and track user access, which are both requirements in HIPAA, you have to secure your data and you have to be able to log what users are logging in and getting information. And that's not just in the EHR system. You need a file server to do that, and it needs to be set up as a domain controller. A lot of offices, particularly smaller offices, will buy a cable service or an internet service from a telephone provider, and as part of the service, they're going to get a router. And the router is that little black box that plugs into the network, and it sometimes gives you wireless capability, but it's what connects you to the internet. And even though some of them say they have some basic firewall features, a business class firewall is required to adequately protect patient data from someone outside your network being able to access it. Well, HIPAA requires encryption. It's what we call an addressable requirement, and a lot of practices have not implemented data encryption. Data encryption is the get-out-of-jail-free card for a data breach. So if you lose a laptop that's full of patient information, thousands of records, you have to report it, you have to notify the patients, you may pay a fine. And that happened to a hospital in Massachusetts when a doctor was traveling and lost his laptop with a couple thousand records. I think it was 2,600 records on it. And they paid $1.5 million in the fine. If that data had been encrypted, they would not have had to report it. They would not have had to pay any fine. No free web mail or file sharing. Business class email, including the ability to encrypt data or using the portal that comes with your electronic health record system, you need to be able to securely communicate with patients and also other practitioners if you need to send anything back and forth. And this includes things that get sent to specialists. We know in the dental business, people are sending x-rays and other things to specialists for their opinion and so forth, but you can't use free webmail. And the examples of that would be like free Gmail or Hotmail or Yahoo, or in some cases what came with your internet service subscription. Vendors have to sign business associate agreements, and they also have to disclose their subcontractors. So even if you're using a vendor that's an email provider, you have to ask them if they own the data center where their servers are kept, and in most cases they don't. So they have to disclose to you information about the data center and verify that the data center is also compliant. And then this coming April, this is just a reminder that Windows XP is going to lose its security patches and updates from Microsoft, and continuing to use it afterwards is both a HIPAA violation because you won't be able to comply with the requirement for protecting devices against malicious software, but also you're going to open yourself up to a lot of risk. There's been a lot of information about pent-up demand or pent-up breaches that are going to occur, and malware that is going to be released after April because Windows XP will be defenseless.
So what do people need to understand about user and system controls?
Okay. I'm going to go through this quickly. HIPAA says you have to have unique user identification, and you have to be able to log exactly who was in the system and who accessed the record. You can't do that with shared logins or passwords. If people are logging in as nurse and the password is nurse or the password is something else, there's no way to take it back to know that it was Mary or Sue or Joan or Jane or whatever who logged in, and that's a violation of HIPAA. Every user needs their own individual login and password. Automatic lockout. Even though it's an addressable requirement, if you don't have automatic lockout, it means that you have to have like attendants in every examining room sitting there with the patients to make sure that the patients aren't walking up to a computer and touching it if all you have to do is jiggle the mouse to get into the electronic health records. So systems have to have electronic or automatic lockout turned on. The time can vary, but if you're closer to patients and the public, for example in a hospital, if you're in a hallway or in a patient room, you would set that lockout to be a lot shorter, maybe 3 minutes, compared to a doctor's work area or a computer at the back of a nurse's station where you might set it for 10 or 15 minutes.
Now, we've been focusing mostly on providers here, but, and we've had other sessions about business associates. What are some quick notes on what business associates need to do?
Well, we spent a lot of time over other webinars and articles out on Format Approved in the HIP security section on business associates, but basically you have to identify your business associates. They have to sign business associate agreements. There are new ones that came out last year. If you're still using old ones prior to 2013, you have until this September 22nd, to replace those. And this is not just an exercise in legal agreements. Business associates have to comply with HIPAA. You're responsible for what they do, and you're responsible if they have a data breach. You could be fined if your business associate has a data breach, so you need to audit your business associates as well as your internal organization.
Now, you talked about this a little bit already, but why is it important to use professional IT services?
Well, Brian, I don't know anybody that has gone from being an IT specialist to being a doctor. So when it comes to setting up a business class computer, a firewall, a network, getting all the security in place, making sure that you can go back and audit it. For example, is the firewall working? And you have to know how to be able to check to see that the intrusion prevention service is functioning on the firewall. And you need to be able to download things like intrusion prevention, intrusion detection reports off the firewall. On the computers, you have to be able to validate who's accessing the systems, and making sure that the logging is being done and that the logging is being saved so you can comply with the HIPAA requirement for 6 years. So business class technology requires professional installation. The fact you take it out of a box and hit next, next, next when you're setting something up does not mean that it's set up securely. There are a lot of settings that have to be made in these systems. Once the settings are made, you can't set it and forget it. You have to have a way to monitor the systems on an ongoing basis. So one of the data breaches last year was at a university, at Idaho State University, in one of their medical clinics, when a firewall had stopped functioning. It had stopped blocking intrusions. They didn't catch it for 10 months, and there were like 17,000 patient records that were breached. So you need to be able to monitor the network, because even if security feature fails, it doesn't mean that the whole system's going to go down and you're going to realize you have a problem. So there are things that can happen silently that need to be monitored using monitoring tools that an IT professional would have. You have to have ongoing management. People change, systems change. You have to have users added and deleted, and a new piece of equipment may be added to the network, and it needs to be set up securely. And then the last thing, as we said early on, in order to prepare for an audit, you have to have good documentation. So the documentation of all these technical services is important, and I have yet to meet a doctor in, well, actually my whole life, not just 10 years of doing HIPAA, but forever, that really knew how to do any of these things and document them properly at a level that would sustain an audit.
So this is not the time for people to take a DIY approach. It's not like setting up your Wi-Fi network at home, which, a lot of people can't get that done very easily, but certainly when it comes to protecting patient information, that is not the way to do it.
Right.
So documentation has been a theme throughout your comments here. Real quickly, what's the documentation that people need to pay attention to more than anything else?
Well, this information isn't just coming from what HIPAA says you kind of have to do if you go back and read the rules, but if you look at enforcements and you look at the penalties and the places, the organizations that have been fined, many of them have been fined because they don't have written policies. Now, some of them have a policy, like an acceptable use policy for users, and sometimes it says you shouldn't do Facebook, or you shouldn't, do personal email using the company systems, and in some cases it tells them that they're going to get fired if they breach patient confidentiality. But those could be 1 or 2 pages of documents. That's not sufficient, as I said earlier, to comply with a regulation that's hundreds and hundreds of pages in terms of rules and requirements. So we find that organizations don't have written policies. Policies often include procedures, and sometimes they're separate. We like to keep them separate, but we've had organizations that have had policies and procedures that were written in 2003 to comply with HIPAA, and they've never been changed. And we'll ask them questions like, are you still using that IBM System 36 or an older type of system? And they'll say, no, we got rid of that years ago. Well, that's in the current policies and procedures. So that shows that they weren't updated, and that in itself is a HIPAA violation. Evidence, and the term evidence will keep coming up in an audit. Do you have evidence of HIPAA training? Do you have evidence that you're actually doing the things that you say you're doing? Do you have evidence that your IT department or your outsourced IT provider is providing HIPAA compliant services? We talked about audit logs, but there's all sorts of documentation that has to be kept for 6 years. So they have every right to come in and say, show us all the audit logs for April of 2009 and every activity, who logged into the system, what they accessed, and everything. And I don't think there are very few organizations in healthcare that could provide that. Things like signed confidentiality agreements. HIPAA has a requirement for a sanction policy. Can you show that your employees have received it? And then we've talked about vendors. You have signed business associate agreements. And it's pretty easy to walk in and say, do you use an answering service, do you use a collections agency, do you use a shredding company? And as we get yes, yes, yes to those questions, we'll ask, can you show us the business associate agreement that you have with that organization? And many times we find that they're not there.
So here's a great question. Is an audit just a one-time event?
Well, in theory it could be, but here's the problem with auditing. if you audit anything, and let's kind of use audit as the lowercase a audit, where you're going to do an internal audit and you're just going to inspect what people are doing within your organization. If you do HIPAA training once a year, for the next couple of days, and you may walk around and you see people that are following the training that they just received. As time goes on, and also as you have turnover within your organization, you're going to find that people have gone back to their old habits. We've used to have nurses walking around with their logins and passwords on tape on the back of their badges, and we got them to change that. It was a real issue, because if their badge turned around, we'd walk up and be talking to somebody, and if we looked down at their name tag, because we couldn't remember their name, we might know their login and their password, but their name and their face were facing away from us. So people go back to old habits. New employees come. So if you do annual training, you have to make sure that your HR department is following through to make sure that the new employees are getting their HIPAA training. New processes. In the course of a year at a hospital or medical practice, new equipment may be implemented, new systems may be implemented. There's a lot of consolidation going on now within healthcare, so you may have bought a practice, or your practice may have been bought, so you have new processes. It can take a long time to build the compliance to where you want it, but it can take just seconds to create a violation, and the simplest example I give people is if someone writes their login and password on a Post-it note and sticks it on their monitor. That takes just seconds, but that would blow up a HIPAA compliance program very quickly. And then you have different levels of auditing. There's technical things. For example, can you show that your systems are logging access? There are administrative controls. Can you show that your people have received training? And then there's physical auditing to walk around and make sure that systems, for example, laptops, aren't being left where people could steal them, and or locked, just thrown on the back seat of a car as opposed to being locked in a trunk.
And here's one we hear about all the time. And I wish I had art for this that was a doctor operating on himself, but can you just address this question? Can someone audit themselves?
Well, the simple question is, of course you could audit yourself. However, what's the goal here? Are you trying to meet some requirement that said you have to have a piece of paper or a report, so you're going to do it yourself or buy a kit and put it on the shelf and take it off the shelf and hope that you can understand it? Our experience is, and we do a lot of audits, and we send questionnaires out and we'll talk to people and do interviews with them on the phone. They don't have the expertise. The healthcare people that we've talked to, including the IT staff, they don't have the expertise to identify all of the areas that would fail an audit. And our goal is not to fail an audit. When we're working for a healthcare provider and we're doing a risk assessment or a HIPAA assessment, compliance assessment, we're essentially saying we're going to be just like an external auditor with that critical third-party view of your organization, and we're going to give you a report that shows you what things need to be fixed without the fines and the penalties attached. So most of the people don't have the expertise. Many of them don't have experience. So even if you knew a lot about technology, you don't have a lot of experience necessarily with HIPAA and the enforcements and understanding things like the penalty for the firewall failing, or there was a lost thumb drive recently, or the copier, the information that was on copiers that cost a health plan $1.2 million just a few months ago. And what we found is that when people have sent us audits that they have done themselves, they're not comprehensive, they're not thorough, and they just wouldn't sustain a compliance review from a government agency. And then more than anything, as I said before, if you audited yourself for taxes, if you did your own IRS audit, would you ever pay any more in taxes? Most self-audits don't include that critical eye and an independent mindset. Most audits are, if an IT person's doing an audit and they see something wrong with their network, they don't want to show their boss because it may make them look bad. Same thing with a practice manager. If a practice manager sees something wrong in the office, they don't want to cast a bad light on themselves. our audits are not done with like a gotcha mentality. We work with the IT people. We work with the practice managers and say, here's what we're seeing. Here's what we think ought to be done. Let's correct it. And that's the purpose of having the risk analysis done. And the goal is to protect that patient information. And very simply, you have to have somebody take a look at what you're doing. If they see something wrong, just fix it. It's not saying that you're a bad person.
Well, we don't have a lot of time for questions, but I want to remind our audience that that's okay because we're going to provide written answers to your questions. I do think we have time maybe for one, maybe two, but let's get to one at least. And this is a good question because I think it gets to some of the, well, I'll just read it to you, Mike, and let you address it. The question is, can you use personal level email to communicate with patients if there's no health info? That sounds reasonable enough, but then there's another part here. For example, what if you're just communicating billing info?
Well, let's go back to what's protected information for a minute. It has to have a combination of the patient identifier, some way to identify the individual, as well as something about treatment and treatment or diagnosis or payment. So if you're simply going to send something to Mary Jones and say you owe $500, if that's the type of payment info, then that's not protected because there's no information about treatment or diagnosis. If you're saying for the chest x-ray you had last week, you owe us $500, that is the type of thing that is protected. Now, there's kind of two answers to this on email, and I know we're running out of time, but if the practice has to be using a secure email system. If the patient is using something like Gmail or Hotmail or internet service provider mail from like Cox or Time Warner or any of those types of companies, Comcast, whatever, then the patient is allowed to have you communicate with them using that email. They have to request it. But if you're going to have any sort of a conversation that includes their name and or anything to do with diagnostic or treatment information, then you can't just do it across email. This is one of the reasons why the secure patient portals within the electronic health record systems are going to be a required tool for communications with patients.
All right, well, I'm afraid we are out of time for today's session, but as I said before, we're going to send out written answers to those questions from Mike, so look for an email in your inbox on that. That email will also include the slides of this event and the recorded version. So, Mike, thank you for joining us. It's always a real pleasure to have you here.
Thank you, Brian.
And thank you to our audience. We'd like to share some resources with you very quickly. For one thing, to learn more about Mike Semel and his consulting services, please visit www.semelconsulting.com. Mike is truly the best in the business, so you could not do better than to visit that site and get Mike's expertise. Mike is also the author of the HIPAA education that we provide at Format Approved. So you can learn more about that education by visiting www.formatapproved.com/education/courses_security.html. We have two levels of training. One is designed for the security officer that HIPAA requires. That includes updated business associate agreements as a value add. We also have workforce level training that's shorter, more focused on behaviors rather than concepts, and it's very affordable as well. I'd also like to mention that if you need a risk analysis or you need policies and procedures, all of those services are available if you visit www.formatapproved.com/consulting.php. Join us for the next Learning Lunch. You can visit formatapproved.com and click on the Learning Lunch button, which looks like the one on your page there, to learn more about our upcoming Learning Lunches and to register. Our next event airs tomorrow and has the title, "The Forecast for HIPAA and Hosting is Cloudy with a Chance of Compliance." So please do join us for that or some of our other sessions. Keep an eye on your email box on our homepage for other upcoming topics, and thank you again for joining us today.